Hello everyone. Thank you for joining today's Web Interface Kickoff webinar. This series of webinars is for the accountable care organizations, ACOs, and groups that are reporting data to the Quality Performance category of the Quality Payment Program through the CMS Web Interface for the 2018 performance period. These webinars will highlight important information and updates about the reporting quality data and provide ACOs and groups with the opportunity to ask CMS subject matter experts their questions. Please note that these calls will only focus on reporting data for the Quality Performance category. We will not cover reporting data for the other performance categories during these calls. Now, I will turn it over to Sandra Adams from the Center for Medicare at CMS. Please go ahead.
Thank you. Welcome, everyone, and thank you for joining our CMS Web Interface Kickoff webinar. My name is Sandra Adams, and I work on Shared Savings Program Quality with the CMS Division of Program Alignment and Communication. Today, we will go over some CMS Web Interface resources, key dates to keep in mind, reporting requirements, and web interface access. Next slide, please. This is our disclaimer slide. If you have any questions about this slide, please contact the Quality Payment Program Service Center. Next slide, please. On this slide, you will see a list of documents that are now available in the QPP Quality Payment Program Resource Library, and there are hyperlinks so you can access the information easily. Next slide, please. Here are some key dates to keep in mind. The Web Interface Application Programming Trial Period opened on September 11th and will close on January 4th. On this slide, you can see a list of resources for the API interface. Next slide, please. The CMS Web Interface Test Period will open on January 7, 2019 and will close on January 18, 2019. This slide provides information about what you will be able to do within the CMS Web Interface during this time, including logging into the test mode, downloading your sample, reviewing your sample, and working with your data in the Excel template. Uploading your data, manually entering the data, and reviewing the reports that are available within the CMS Web Interface, and also using the API to retrieve your beneficiary sample and map to your EHR data. And note that any test data you upload or enter will be removed at the close of the test data period. Next slide, please. The CMS Web Interface submission period will open on January 22nd, 2019 and close on March 22nd, 2019. During the submission period will close promptly at 7:59 p.m. Eastern Daylight Time on March 22nd, 2019. And your web interface submission will be accepted during that time. And the web interface is accessible through the sign-in link on the Quality Payment Program website. And here's the link. Next slide, please. Please plan to attend the CMS Web Interface support calls listed on this slide. These calls will provide up-to-date information for web interface users and provide an opportunity for you to have your questions answered. We encourage organizations to share these times, dates, and registration information for these webinars with your organization's quality reporting personnel. This slide also includes a link to the webinar flyer. and the dates are hyperlinked to the registration pages for your convenience. Next slide, please. And now we will go over the CMS Web Interface reporting requirements. Next slide, please. Organizations must completely report quality data on the required number of beneficiaries in order to satisfactorily report. This is a minimum of 248 consecutively confirmed and completed beneficiaries for each measure, or 100% of the beneficiaries in your sample if there are fewer than 248 beneficiaries available in the sample. To avoid the 2020 MIPS downward payment adjustment, organizations must completely report all 15 CMS Web Interface quality measures, and MIPS groups and eligible clinicians participating in an ACO must meet MIPS reporting requirements for all performance categories to avoid the downward adjustment. Next slide, please. Shared Savings Program and Next Generation ACOs that fail to satisfactorily report all measures will not meet the quality performance standard and will not be eligible to share in savings if earned. TINs who participate in a Shared Savings Program ACO that fails to satisfactorily report the CMS Web Interface and CAPS for ACOs will get a MIPS quality performance score of 0 unless they report separately from the ACO, either as a group or a solo practitioner TIN. For details regarding interactions between the Shared Savings Program and MIPS, please review the guide available on the Quality Payment Program Resource Library that is hyperlinked here. Next slide, please. And now Chris Reinhardt will present Enterprise Identity Management EIDM resources.
Thanks, Sandra. Next slide, please. Okay. Currently, as it has been in the past, the QPP system and its legacy PQRS system relied on EIDM for the enterprise management system that controlled our access to the system. So we want to call out that we are going to be transitioning very soon from the enterprise identity management solution to a new improved solution that's specific to the QPP application. More information will be forthcoming on that, but essentially it'll be fairly the same process. You'll log into the QPP website. If you don't already have login credentials, you'll go to the sign-in page where there will be links to take you to either EIDM until we transition from EIDM or to the new system wherein you'd be able to create your user account. There's been a number of clinicians in the areas of both web interface and group practices that have participated in some user testing we've done with this new system. I just want to thank anyone on the phone that was part of that. It was extremely useful in understanding our users' needs and being able to develop a system that helps fix some of the issues that we had when we were on the EIDM system. And hopefully this will be a much better experience for everyone. Next slide, please. So what we will talk about now is specific to EIDM. A lot of what I'm going to talk about now will be very similar to the new system, so it's applicable whether we're talking EIDM or the new identity management system we'll be switching to. Essentially, in order to submit data to the CMS Web Interface, you're going to need to have an active user ID and a role to submit data, and in this instance, it's the Web Interface Submitter role. In order to get that role, there must be someone in your organization set up as a security official for your ACO or group practice. If it's someone in a ACO, they would have to have an ACO security official. Otherwise, they'd have to have a security official role for their group practice. And then once you have the security official in place, other users can go in and request a web interface role, and that security official can approve that request. Next slide, please. So as I said, the web interface submitter and the security official, ACO security official, these are all roles that are currently requested through the Enterprise Identity Management System, specifically the Physician Quality and Value Programs application within that EIDM system. The first security official will need to create the organization. So if you're an ACO, your ACO security official, when they request that role, would set up the organization, the ACO organization. And similarly, if you're a group practice, your group practice, when they set up the security official, would be setting up the group practice as well. There's a reminder here to make sure you keep your passwords active so you don't have to go through password reset. Next slide, please. Sorry, I'm catching up. These are some links that we have available to EIDM user guides. So these would be specific to the Enterprise Identity Management System. There will be additional information forthcoming on the new identity management system when we transition to that system. We'll have new user guide. We'll have user videos that would walk you through the process sort of in a tutorial fashion. And there will also be additional announcement information coming from CMS when we launch that new identity management system. Next slide. So any help you need with the Enterprise Identity Management System or the new Identity Management System, you can contact through email the help desk email or call the help desk directly with these numbers. Next slide. All right. Aslam, I'm going to turn it over to you to discuss the CMS Web Interface.
Great. Thank you, Chris. Good afternoon. I'm Aslam Tassel. I would like to show you the steps you'll need to follow to enter the CMS Web Interface through QPP. Next slide. The orange arrows on these images are to direct your attention to areas that you'll need to click on or enter data. To get into the CMS Web Interface, you're going to have to first sign into QPP. So you'll click on the Sign In on the QPP screen. Next slide, please. You will next need to enter your user ID and password. Check the Statement of Truth checkbox to agree, and then click the Sign In button. Next slide. QPP requires two-factor authentication to sign in. A verification code will be sent to your selected method of two-factor authentication. You will have to enter that code here, then click the Submit Code button. Next slide, please. After signing into QPP, on the left navigation menu, click the Eligibility and Reporting link. Next slide. The following steps to navigate to the CMS Web Interface is slightly different for ACOs and groups. First, I will show you the navigation for ACOs. Next slide. Okay. If you are an ACO, when you reach the Eligibility and Reporting page, you will see a page that looks like this. Above the Eligibility and Reporting page title, program year 2018 will be selected by default. Under the APM Entities tab, there will be a list of APM entities that your account is associated with. Next to each entity on the list, you will have a Start Reporting button. Once you click on the Start Reporting button, you will enter the CMS Web Interface for the selected APM entity or ACO. Next slide. And here you see the landing page for the CMS Web Interface. On the left-hand side, there's a navigation menu where you can click to navigate to View Progress, Report Data, View Reports, Manage Group, and Frequently Asked Questions. On the right-hand side, there's a Milestone Timeline that helps you understand where you are during the test and submission periods. Next slide, please. If you're a MIPS group, then you have a few extra steps. Next slide. On the Eligibility and Reporting page, select the Practices tab to see a list of practices your account is associated with. Next to each practice name, you will see the Report as a Group button. Click on the Report as a Group button. Next slide. You will be navigated to the Reporting Overview page. In the Quality section of this page, click on the Start Reporting button. Next slide. The Upload Quality Data pop-up will be displayed. Under Option 2, you will see Go to the CMS Web Interface button. Only those users whose group practice has registered for the CMS Web Interface will have this selection. If your group practice is not registered for the CMS Web Interface, you will not see this button. Next, click on the Go to the CMS Web Interface button. Next slide, please. And here you reach the CMS Web Interface landing page that we saw for ACOs. It has the same left-hand navigation, the same milestone timeline, and the same options on the page. Next slide. Okay, now I'm going to pass it off to Sarah.
Thank you, Aslam. So essentially what the CMS Web Interface is allowing organizations to do is to report on a predetermined set of beneficiaries. So in order to determine those beneficiaries that are eligible for web interface reporting, we follow this general process. Next slide, please. So first, beneficiaries are assigned to an organization. Then their quality eligibility and their denominator eligibility are determined. And lastly, they are selected or sampled into the applicable measures and loaded into the web interface for quality reporting. Next slide, please. So assignment is essentially the algorithm that's used to determine where a beneficiary receives the plurality of their primary care services. And because assignment is rerun every year, it is possible that a beneficiary assigned to an ACO or group in one year isn't necessarily assigned to that same ACO or group in the following year. For web interface reporting purposes, the following assignment runs are used. For the Shared Savings Program, third quarter assignment is used for the Next Generation ACO program. The list of prospectively aligned beneficiaries updated with exclusions from quarter 3 is used. And for MIPS groups, the assigned beneficiaries as of October 26, 2018 were used. Next slide, please. And here is a link of the different documents, or a slide that has links to the different documents for each of the assignment methodologies. If you want to dive into these details in any greater depth, they are all linked for you here. So the MIPS group assignment methodology, the MGACO alignment methodology, and the shared savings program assignment methodology specifications. Next slide, please. So this slide outlines the steps that are taken for the actual beneficiary sampling into the measures. And the first step is determining quality eligibility for reporting. So that includes ensuring that the beneficiary is not in hospice, hasn't moved out of the country, hasn't enrolled in any non-fee-for-service Medicare plan, like a Medicare Advantage plan, and hasn't passed away. It's at this step that we are also looking to determine if a beneficiary had 2 primary care visits within the ACOR group during the performance year. So if they haven't, they are excluded from the sampling process at this step. And the next step is determining if a beneficiary is denominator eligible. So for each measure, we have certain criteria for denominator eligibility, which include age, visits, and/or diagnosis criteria, and those are all applied at this stage. And then the last step is the actual selection of the sample for each, for all the denominator eligible beneficiaries, and it's for each measure. Next slide, please. So the first step of that selection process is that beneficiaries are randomly selected from the quality eligible pool, 900. We start with 900 if possible, keeping in mind that each measure will have its own beneficiary sample. So there will be 13 samples of 616 beneficiaries and 1 sample of 750 beneficiaries. That's the PREP 13 statin therapy measure where we provide that oversample. From the 900, 616 or 750 are populated into a sample. Efforts are made to select beneficiaries into as many measure samples as possible, so as many as they are eligible for. Each beneficiary is given a rank or a place in that sample. If a beneficiary qualifies for more than one measure, we try to give that beneficiary a similar or close rank for any other sample into which they are ranked. For PREP 13, there are a couple additional interim steps there that are taken to try to achieve an even distribution across the 3 different risk categories that are required for that measure. Each organization is required to confirm and complete data entry on 248 consecutive beneficiaries for each measure, or 100% of beneficiaries that are included in the sample, as Sandra had mentioned earlier. If you would like to read more up on the sampling methodology for Performance Year 2018, there is a link here, and it is available on the Resources Library page of the QPP program website. So I will pass it back over to Oslam now. Next slide, please. She will be reviewing the Excel beneficiary sample download and upload. Thank you.
Thank you, Sarah. Hello, this is Oslam again. I'd like to show you the Excel beneficiary sample download and upload functionality. Next slide. So once you're in the CMS Web Interface, it's very easy to work with the Excel bulk download and upload process. On the left navigation menu, there's a Report Data button. Click on this button to navigate to the Report Data page. Next slide. And you'll see an area on the Report Data screen for downloading your sample and for uploading your data. On the left box, you're going to click the Download button. Next slide. On the pull-down menu, you'll see two types of download options. The first option is beneficiary sample without data, which downloads only pre-filled CMS data. This download is the original sample before you input any data into the CMS Web Interface. The second option is beneficiary sample with data, which downloads data that you have already entered into the CMS Web Interface, either manually, via a previous Excel upload, or via the API. Most often, you're going to select the beneficiary sample with data, which will include all the data you have entered to the CMS Web Interface to date. Select that. Next slide. Click the Download button to start the file download process. Next slide. Once your data download is complete, you're going to populate the spreadsheet with your beneficiary data. Your beneficiary sample will be included in the spreadsheet along with all of the data reported so far against the measures for those beneficiaries. The columns that are light gray in color, such as beneficiary ID or measure rank, cannot be changed. If a beneficiary is ranked in the measure, then the question input field will be white or light blue, meaning that you can edit these fields. If a beneficiary is not ranked in that measure, the fields will be dark gray, and you don't need to enter data in these fields. The measure questions have drop-down menus to help you populate those cells with the correct values. Any fields that are left blank will not be saved in the system. Similarly, any data previously entered in the system will not be overwritten. For questions where you want to intentionally save a blank in the system, you can select NA. You can submit any amount of data at any time through the Excel upload process. Next slide. Once you populate your Excel file with the data that you want to upload, you can either drag and drop it into the Excel upload area, or click the Browse link and select the file that you want to upload to the CMS Web Interface. Next slide. You will be presented with a confirmation pop-up. Click on the Upload button to start the file upload process. Next slide. During the file upload, a progress pill will be displayed on the bottom left of your screen. All of the data that's included in your Excel spreadsheet is processed real-time during the upload process. Next slide. Once the file upload is complete, if your Excel file contained any errors, you can view these errors on the Excel Errors tab on the Report Data page. During the file upload, the system will not update the measured data for which errors are found. You'll need to re-upload the Excel file with correct data or manually enter the data to fix the error. Next slide. Okay, now I'm going to pass it off to Angie.
Hi, this is Angela Stevenson to give you an overview of the 2018 CMS Web Interface measures and resources. Next slide, please. The 2018 CMS Web Interface measure specifications and supporting documents are available in the Quality Payment Program Resource Library. There you will find a list of the 2018 CMS Web Interface measures. The list will include the measure number, title, alternative measure numbers that are used for other programs, and the measure owner. The measure specifications contain both the narrative measure specifications and performance calculation flows. They include the measure ID and name, the NQF number, if applicable, the measure description, and improvement notation. They provide the specifications for patient population, denominator, denominator exceptions and exclusions, numerator, numerator exclusions, definitions and guidance, rationale, clinical recommendations, and measure flows with sample calculations for performance rates, as well as downloadable resource mapping tables. You'll also find the 2018 CMS Web Interface coding documents. These are Excel workbooks that provide codes used to identify encounters for patients in your sample, denominator codes, including exceptions, exclusions, and drug codes if applicable, and numerator codes, including exclusions and drug codes if applicable. The coding for the measures is considered all-inclusive for EHR mapping purposes, but you can use medical record documentation to meet the intent of the measure. When submitting data through the CMS Web Interface, the expectation is that the medical record documentation is available that supports the action or the code reported in the CMS Web Interface. The release notes document is also available, which lists the changes to the existing measures since the release of the 2017 CMS Web Interface measure specifications. Next slide, please. The CMS Web Interface measures on this slide have not changed. The measure itself has not changed, but they may contain updates in the specifications to help clarify the intent of the measure. There are updates to the 2018 coding documents for all measures which are reviewed and updated annually by the measure stewards. Next slide, please. The CMS Web Interface measures that changed in 2018 are the CARE 2 Falls, Screening for Future Fall measure, the PREV 9, Preventative Care and Screening, BMI Screening and Follow-Up Plan, and the PREV 10, Preventative Care and Screening, Tobacco Use Screening and Cessation Intervention. Next slide, please. The CARE 2 Falls Screening measure changed for 2018. The medical reason denominator exception for non-ambulatory patients was removed, and it was added as a denominator exclusion. The exclusion includes patients who were assessed to be non-ambulatory during the measurement period. The denominator guidance was added, which states to count the patient as non-ambulatory only if they were non-ambulatory at the most recent encounter during the measurement period. And there are no denominator exceptions now for the measure. Next slide, please. The PREV 9 BMI Screening and Follow-Up Plan measure changed for 2018 also. The look-back period for the BMI, or the BMI with follow-up plan when the BMI is abnormal, was changed from 6 to 12 months from the most recent visit in the measurement period. The measure description and numerator were updated to reflect the 12-month look-back period. Next slide, please. The PREV 10 Tobacco Use Screening and Cessation Intervention measure changed significantly for 2018. There are now 3 measure rates required to be reported. The percentage of patients aged 18 and older who were screened for tobacco use 1 or more times within 24 months is the first rate. Percentage of patients age 18 and older who were screened for tobacco use and identified as a tobacco user who received tobacco cessation intervention is a second rate. And this is the rate that will be used for performance calculation. The other rates are required to be reported but are informational. The third rate is percentage of patients age 18 and older who were screened for tobacco use 1 or more times within 24 months and who received the cessation if identified as a tobacco user. Next slide, please. The denominator for the measure for population 1 equals the initial population. For population 2, the denominator equals the initial population and those who were screened for tobacco use and identified as a tobacco user. Population 3 also equals the initial population. The denominator exceptions for each population vary a little bit. The population 1 exception is documentation of medical reason for not screening for tobacco use. An example is limited life expectancy or other medical reason. For population 2, the exception is documentation of a medical reason for not providing tobacco cessation intervention, because those patients are only the ones who are identified as tobacco users. The population 3 is documentation of medical reasons for not screening for tobacco or for not providing tobacco cessation intervention for patients identified as tobacco users. Next slide, please. The numerator for PREV-10 for population 1 is reported as patients who were screened for tobacco use at least once within the 24 months. Population 2 numerator are patients who received tobacco cessation intervention. Population 3 are patients who were screened for tobacco at least once within 24 months and who received tobacco cessation intervention if identified as a tobacco user. Okay, thank you, everyone. I'll now turn it over to Katie Moore.
Thank you, Angie. Next slide, please.
Thank you.
On this slide, you'll find a list of available resources. The Help and Support page at qpp.cms.gov contains links to materials such as videos, webinars, and online courses, as well as other items to help with reporting and development. The Quality Payment Program Resource Library also contains documents to assist with reporting via the CMS Web Interface. The items currently listed on this slide, as well as some of those mentioned by Sandra earlier in the presentation, are currently available on the Resource Library, and will communicate any future postings and upcoming support calls. Next slide, please. This slide contains links to resources available for Medicare Shared Savings Program and Next Generation ACOs. Next slide, please. This slide contains the contact information for requesting additional assistance if needed. Now I'll hand things back over to Michaela for the Q&A session. Thank you.
All right, next slide, please. We are now going to start the Q&A portion of the webinar. You can ask questions via the chat or via phone. To ask a question via phone, please dial 1-866-452-7887. And if prompted, please provide the conference ID number 759-8466. So for our first question, it says, in the coding documents, what does it mean when for CMS sampling use only is next to the code? Does that mean that these codes cannot be used for EHR mapping?
Hi, this is Jessica from the PIMS Measures team, and this question is referring to a sheet within that coding document, and the encounter code sheet lists codes that are used to assign beneficiaries into the measure within your web interface platform. It includes resource codes only. You may use that list to locate a place in the medical record where the denominator encounter occurred, so then you can look for the quality action performed around that encounter. The quality set lists in the measure documentation are aligned with ECQMs whenever possible. These codes are updated by CMS on a yearly basis, and they are considered all-inclusive if you are mapping your system from your EHR. And you may utilize any information supported in the medical record. However, to address compliance with this measure, we strongly recommend, again, to use any information within the medical record around that code. Does anyone else from any of the other teams want to speak to that, or did that cover it? All right. Thanks, guys.
Thank you. Our next question is, will the sample file have both the HICN and MBI in some cases? Do we know if the file will primarily have more of the HICN number or more of the MBI for patients?
Hi, this is Sarah Grallert from ACO PAC. I can take this question. We are providing one beneficiary identifier. It will be either the MBI or the HICN, but there will be a flag, a field that also flags if that identifier is the MBI. We are using the most recent identifier that we can gather in claims to populate that field.
Thank you. The next question is, we have beneficiaries attributed to physicians that have been removed from our ACO. What do we do if those patients appear in our sample?
This is Olivia from ACO PAC. I can take a first stab at that. Basically, the patients have still been assigned to your ACO, and your ACO has still agreed to be responsible or accountable for the quality and cost of care provided to them. So you are expected to continue reporting on them. In addition, more generally, we are anticipating you will work with providers both inside and outside the ACO to support this data collection.
Thank you. The next question is, if we held the web interface submitter role for the 2017 submission period, do we need to do anything further to have this role for 2018?
Hey, this is Chris. So that's a very important point I missed covering when I was talking about our new identity management solution. If you've in the past established the EIDM account and associated that with a QPP role, we'll be migrating all of that information from EIDM to our new identity management system. So if you previously held that account ID and role, that should be still valid for you once we transition to the new system. And if you have never established an EIDM account with a QPP role, then you would have to set that up new within the new system. But for the majority of our users who have previously been submitters, all their account ID information and roles should transition across, and you shouldn't have any tasks with the identity management system.
Great, thank you. And Stephanie, do we have anyone on the phone for questions?
At this time, if you would like to ask a live audio question, press star then the number 1 on your telephone keypad. Again, that's star then the number 1. And we do have a question from Jason Shropshire.
Hi, can you hear me?
Yes.
Are you going to release a Q&A document as you have in years past regarding the quality measures? There's many frequently asked questions that are very helpful.
Hi, Jason. This is Jessica from the PIMS team. That link did go live recently on the Quality Payment Program Resource Library, and it was referenced earlier in the presentation. So please do go to the Quality Payment Program, and when you get to the website in the upper right-hand corner is the link, About Us or additional information, and that will send you to the Resource Library. under the About drop-down, there's the Resource Library, and when you go there, then you'll be able to filter and identify web interface applicable resources. So yes, the question and answer document is now available. Thank you.
Great, thanks.
Thank you. And our next question is, will the new identity management system allow you to maintain access to the CMS portal as well?
This is Chris again. The ID should be shared between the identity management system or the CMS portal and QPP, so that EIDM ID or OCT ID, as it's frequently referred to, would be the same. The roles specific to QPP would only be within the QPP system, and conversely, the roles specifically outside of the QPP would be on the enterprise portal.
Thank you. Our next question is, are there disadvantages to confirm and complete date entry for more than 248 consecutive beneficiaries?
This is Olivia, and I can take that one. The answer is, unfortunately, it depends. So if those additional beneficiaries that you confirm and complete beyond the 248 are numerator compliant, then it would be advantageous. If they are not numerator compliant, then it may not be advantageous. So unfortunately, it depends.
Thank you. And Stephanie, do we have any more phone questions at this time?
We have a question from Dr. Charlotte Goon.
Hello. You may have stated this, but if so, I missed it. When will our patient lists be released for doing our audits?
Sandra, will you be able to address that question, or Fiona?
This is Fiona from the Shared Savings Program. Are you talking about, what do you mean by audit? Let me first clarify and get some clarification on your question before we answer.
Yes. You're going to give us 600 and some patients per measure. And so when will those be released? Will those be released when, like January 2nd or January 7th, when the system opens up for us to do training or do practice? So, when will we get those lists that will be in that Excel spreadsheet?
Hi, this is Sandra. The beneficiary sample will be available on January 7th when the CMS Web Interface test period opens.
Thank you. Our next question is, what happens if you want to overwrite or make a change to data you submitted prior to the deadline? How do you manage that?
Hi, this is Aslam. Any data that you enter in the web interface until the submission closing period will become part of your reported data. If you upload any data during the submission period at any time, you can go back to the CMS Web Interface and change the data you have entered.
Great, thank you. The next question is, what constitutes a telehealth encounter?
Hi, this is Angie from PIMS. A telehealth encounter is not specified, it does not have to be a Medicare reimbursed telehealth visit, and it's not defined specifically by CMS for the purpose of the 2018 web interface measures. If measures allow telehealth, then the information for the numerator can be obtained over the telephone, email, and so forth. Thank you.
Thank you. This next question is, will CMS provide a quick reference guides for the measures as you've done previously?
Hi, this is Jessica from the PIMS team. So under the Quality Payment Program, all information related to web interface reporting is available in the measure specification and supporting document zipped folder. And within that folder are the measure specs, which now include the flows and some of the information that used to be in the quick reference guides. Other information was then assimilated into the coding documents. So all the information that used to be in the quick reference guides are now available in the other resources. If you go online and there's a table that you remember using, or if there's some type of resource you remember using that you can't get your hands on, please contact the Quality Payment Program and we can help look into that with you. Thank you.
Thank you. This next question is about Care 1. If the post-discharge medicine reconciliation was done during a telehealth encounter, does that encounter satisfy the office visit requirement in order to be included in the denominator?
Hi, this is Jessica from PIMS again. Yes, there are a couple questions about Care 1, and we do ask folks having those questions to reference the measure specification in the numerator guidance on page 9. It does indicate that telehealth encounters within the 30 days do count for the measure. If you have a unique situation in which a patient may have been discharged and readmitted, if you have multiple issues and you're having trouble understanding how this applies to the situation, then please call the Quality Payment Program Service Center and we will address that situation. Thank you.
Thank you. And Stephanie, do we have any questions on the phone right now?
Our next question is from Mike Rufo.
Hi, everybody. Can you guys hear me okay?
Yes.
Yes, we can hear you.
So this is actually a follow-up to a question I had typed. We have some people that remove themselves from our ACO, but we obviously still have their beneficiaries assigned to us. My question was more about if we can't get their medical record data because those providers are not sharing it with us, what do we do in that event?
This is Olivia. I'll follow up on that answer that I previously provided. Obviously, we do expect you to make your best efforts to kind of coordinate with other providers. But in a situation where you absolutely are not able to kind of access the patient's medical record, then it would be appropriate to use medical record not found in the CMS Web Interface.
And the company we're working with told us that if there were a lot of those that the upload might fail and that maybe there was a way for us to submit those to the QPP and that we should then follow up, that we would get some sort of reference number if those patients are sampled. Is that?
Awesome. Can you speak to being able to upload with a high rate of medical record not found?
The answers in the spreadsheet, such as high number of medical record not found, is not going to impact the upload process. The file will be uploaded and the data will be reflected according to the data upload in the web interface. This will obviously will impact your skip rate, the number of beneficiaries you have skipped, but it will not technically impact the upload process.
Thank you.
Thank you. So this next question, this person says, our care management software uses both claims and clinical data for calculating population health and all quality measures. If claims data determines that a measure has been met at the time of the primary care visit in 2018, is it acceptable to contact the provider and document the exam into our clinical EHR during the reporting period?
Hi, this is Angie from PIMS. The CMS Web Interface measures should be completed based on the information available in the medical record prior to the end of the measurement period. But CMS does not dictate protocol for obtaining quality data. If the information is available in the record at the point of care, it can be used. Thank you.
Thank you. Regarding PREV 10, which population did the presenter say would be used for performance calculations?
Hi, this is Angie again. Population 2 is used for performance calculation. So your denominator are your patients that were screened and identified as tobacco users, and the numerator are then those that were provided cessation. Thank you.
Thank you. And this next question is on PREV 9. The numerator guideline for BMI documentation on page 10 says that the 12-month look back can be calculated at less than 13 months from the most recent encounter. Should we also calculate the 12-month look back for the follow-up plan as less than 13 months?
Hi, this is Angie. Yes, the follow-up plan must be documented at the same encounter as the abnormal BMI. You would use the same look-back period for both.
Thank you. And Stephanie, do we have anyone on the phone right now?
Our next question is from Sandra Santangelo.
Hi, thank you for taking my question. It's around PREV 10. I'm just having a little difficulty understanding the bullets between the second and the third. I understand the second is what we're going to be using for the reportable tobacco user who had smoking cessation, tobacco cessation. What does the third bullet actually, it doesn't look different to me other than the 24 months. So what are the differences between those two bullets?
Hi, this is Angie. The first rate, I'm sorry, you're asking about the third rate. The third rate is the entire population, and then it is going to include both tobacco users and non-tobacco users. And then if a tobacco user, did they receive tobacco cessation? Does that make sense?
You know, I guess I'm just reading it, and I'm seeing like all the same definitions. For the second bullet says 18 or older, screened for tobacco use and identified as a tobacco user and received tobacco cessation intervention. And then the third says 18 and older, screened for tobacco use one or more times in 24 months. That's the only difference I see. And received tobacco cessation intervention if identified as a tobacco user.
Okay. Population 1 is really the population, and then the numerator is those who were screened at least once in the 24-month period. So that's just for screening. And then population 2 are tobacco users only that were screened, or I'm sorry, yes, and then identified as tobacco users. And then 3 is everyone that was screened.
I see it now. I do see it now. Thank you so much.
Okay, you're welcome.
All right, our next question is, for the long-term care point of service exclusions for HTN2, PREV 5, and PREV 6, if we find the POS code in claims but cannot find evidence in the medical record, should we still exclude the patient?
Hi, this is Angie. No, I don't believe so. You can only select the denominator exclusion if there is actual medical record documentation indicating the patient is 65 or older during the measurement period and would reside in any of the types of long-term care that are described by the POS, the place of service codes. Thank you.
Thank you. The next question is, does Care 1 count if done over the phone with social workers and nurses if the medical provider signs off on the note in the EHR record?
Hi, this is Jessica from the PIMS team. Yes, that would count. CMS does not dictate the internal workflow used in a clinician's office, and the CMS Web Interface Measure quality actions are intended to be submitted by the clinician, but there are situations where other healthcare staff may actually document the action, but as long as the eligible clinician signs off on it, then yes, for those quality actions that do allow telehealth contact, then it would count. Thank you.
Thank you. The next question is, what time will the test period begin on January 7th, 2019?
Hi, this is Aslam. The test period will begin at 8 a.m. Eastern Time.
Thank you. And Stephanie, do we have anyone on the phone at this time?
No additional questions at this time. If you would like to ask a question, please press star, then the number 1.
Great. And reminder, too, to just keep sending your questions in through the Q&A box as well. So this next question is, what is the consequence of having a high skip rate?
Hi, this is Sandra. We do expect for ACOs to work with other providers to obtain the medical record documentation. However, there's no problem within the web interface for a high skip rate. However, for the shared savings program, we do evaluate data anomalies, and if there is a high skip rate, we may ask for an explanation, and we may also include ACOs with high skip rates in audits.
Great, thank you. The next question is, are we required to submit reporting CPT codes within our claims submission in order to meet the quality measures?
Hi, this is Angie with PIMS. You would not submit claims any differently with regard to billing CPT codes than you normally would to report measures. But you would submit the quality data codes when submitting by claims to note the quality measure. Thank you.
Thank you. The next question is, will the sample provided during the test period be only a subset of our actual patient population, i.e. only 20 patients, or would it be the entire 616 or 750 beneficiaries per measure?
Hi, this is Sarah Growlert from ACO PAC. It will be your entire sample, so it will be the same sample that you use for reporting. 616 and 750 for Prep 13.
Great, thank you. This next question is, you mentioned the samples need to be consecutive. Can you please explain that further?
Alton, is that one that you would like to take, or this is Olivia and we can attempt to take it?
Hi, this is Sandra. The sample is in a specific order, so the beneficiaries are numbered 1, 2, 3, 4, and so you would go in order to complete the beneficiary sample. You don't have to enter the data in order, but you cannot skip any beneficiaries and not supply data for the beneficiaries.
Hi, this is Azam. I would like to add one more thing to it. If you skip a beneficiary, who is ranked in the minimum required 248, then you will need to report on one additional beneficiary. So for example, if you skip beneficiary number 10 and report up to 248 because you have skipped one beneficiary, your new minimum requirement will be 249. So you will need to report on the beneficiary number ranked 249 to complete your minimum reporting requirement.
Thank you. And Stephanie, do we have anyone on the phone line right now?
We do have a question from Kelly Lane.
Hi. Hello?
Go ahead.
I was checking back on the tobacco measure. I don't see any specific mention of the patients who screened negative. Are those not being counted, or are those implied in population 3?
They are included in population 3. I'm sorry, this is Angie from PIMS. So population 3 is going to include those identified as users and non-users.
Okay, that's what I wanted to clarify since I did not see them specifically called out. I thought they may be implied there, but wanted to identify that for sure.
Okay. Thank you.
Great, thank you. Our next question is, I need clarification on what role is needed for ACO Web Interface reporting. Is it the ACO Security Official role or the Web Interface Submitter role?
Yeah, the answer changes slightly dependent upon which system you go into. So we'll assume you're in the Enterprise Identity Management System. The ACO Security Official role does not have the ability to submit data, so that role is necessary to establish the ACO organization and to approve other users. The ACO Submitter role is necessary to actually have the functionality to log into QPP and act as a submitter. So that role is the one that's required to actually submit, but a precursor to that is someone in the organization has to first have the ACO Security Official role.
Great, thank you. This next person says when they log into QPP today, they're not connected to any practices, and they noted that they're reporting for a NG ACO.
Hi, this is Aruna. Please write to the QPP Help Desk, qpp@cms.hhs.gov, and you can also send the ticket number to the NGACO Help Desk, and we can also look into it. Thank you.
Hi, this is Sandra. I would like to make a clarification on the earlier question about the EIDM ACO Security Official role. The ACO Security Official role can report data as well as that role is needed to approve new users for the ACO.
Thank you. This next question is about the attribution list for PREP 13. It stated that you try to ensure that there's an even amount of patients for each population group. Is this represented in the order of patients, the first 250 ASCVD, the second 250 LDL greater than 190, or hypercholesteremia, and then the third 250 DM patients, or are they scrambled?
Hi, this is Sarah from ACO Pact. The beneficiaries are random, so they would not be 250, 250, 250 in the sample.
Thank you. This next question, this person says, we moved from MSSP in 2017 to NGACO in 2018, and they say that their EIDM account has the CMS Web Interface Submitter role listed in the portal. And within the QPP website, under the Eligibility and Reporting tab, they're not connected to any practices. And I'm sorry, this looks like a similar question to the one we just read out. So I'll go on to the next question. So this next one is on Prev 10, and it says that the second population is the rate which would be used for reporting. Does that mean that the population sampling which will be provided would include patients who are considered already tobacco users?
Hi, this is Angie with PIMS. No, the patients in your sample will not be narrowed down in that fashion. That's going to be determined based on the answers to the questions that you provide in the web interface for the patient. You're going to answer if the patient was qualified, were they screened at least once in the measurement year or the year prior, and if screened, were they identified as a non-tobacco user, or were they identified as a tobacco user? And then if a tobacco user, during the most recent screening, did they receive the cessation? So by answering those questions, that will put the patients into the appropriate population. But the sample will be just everyone, the initial population. Thank you.
Thank you. And Stephanie, do we have anyone on the phone with questions at this time?
We have a question from Ken Perkins.
Hi. Quick question. I think I have this one answered. Last year there was an update to the Excel file in early January based on different than the one that was sent out the previous November. Are there plans to do this again this year?
We are not aware of any changes that are needed in the Excel template at this time. If there are any changes that needs to be made and that the file needs to be reposted on the resource library, there will be some form of communication to let you know.
Okay, but at this point, no changes anticipated.
No changes anticipated, correct.
Thank you.
Thank you. And we have another question relating to Prev 10. And this person's asking, so for is a patient a tobacco user with the answer patient is smoker, cessation counseling given. Is that acceptable for numerator compliance?
Hi, this is Angie. The screening questions need to indicate the patient was screened for both smoking and smokeless tobacco. If the documentation shows the patient's tobacco use status is that they are a current smoking tobacco user and that they were given cessation, that would be acceptable. Mary or Olivia, do you have anything to add to that regarding if only patient is smoker, counseling given was documented?
Hi, this is Mary. That measure requires looking at all forms of tobacco use, so the answer is correct. We would look for something other than just smoking.
Thanks, Mary.
You're welcome.
Thank you. Our next question is, will the sample of patients for Prev 10 be the same for populations 1, 2, and 3?
Hi, this is Sarah from APOPAC, and yes, the sample is the same, and it's just how the questions are answered, which determines into which population the beneficiary lands. But the sample is just the one sample.
Thank you. This next question is, we have several individuals that need access to the web interface. Do they all need the role of security official in order to reach the patient data?
Could you please repeat that question?
Yes. So they said we have several individuals that need access to the web interface. Do they all need the role of the security official in order to reach the patient data?
No, the initial approver would need to get the security official role. That security official would be able to approve other role requests, be that additional security officials or role requests for this submitter role.
Great, thank you. This next question is, if claims were made within the measurement period, but the actual documentation found, will that suffice? For example, 1111F was coded, but there is no discharge meds reconciled noted in the progress note.
Hi, this is Sandra. If claims data can be used to locate patients, however, if in the case that an ACO is selected for an audit, you would need medical record documentation. You would need to provide that as part of the audit. And medical record documentation should be available for all groups and ACOs to support the data that you're entering into the web interface.
Thank you. And Stephanie, do we have any phone questions at this time?
We have two more questions, one from Trudy Percy.
Yes, I was calling to ask if you have any intention of including CQL in your narrative specifications.
Hi, Trudy. This is Jessica Schumacher from the PIMS team. So CMS is not including it, obviously, for the 2018 program year. So unfortunately, it will not be available this year. Regarding upcoming program years, CMS is finalizing the 2019 measure specifications. I know that we have a couple questions in the queue about those, and those will be posted shortly. I believe it might be best, and Sandra, please correct me if I'm wrong, to provide that recommendation during the public comment period for the next proposed rule. But unfortunately, I don't believe we're able to speak to future documentation, and we'll just be focusing on 2018 today. Thank you.
Thank you. This next question is, did I understand that beneficiaries will be excluded from the sample if they have not had at least 2 PCP visits?
So this is Sarah from ACO PAC. The visit needs to be a primary care service, and I believe in some instances it will not necessarily be provided by a primary care provider. So that's the determination for those 2 visits.
Thank you. This next question is, how is performance period defined under the denominator exclusions for MH1? Is this the measurement period, denominator ID period, measurement assessment period, or another time frame?
Hi, this is Jessica from the PIMS Measures team. So in order to claim an exclusion, there must be an active diagnosis of bipolar documented in the medical record, and it has to occur during the denominator identification measurement period or the measurement assessment period. So anytime, again, between the denominator identification measurement period or the measurement assessment period. And this is stated on page 9 of the measure spec in the denominator exclusions definition in the guidance box at the bottom of the page. Thank you.
Thank you. This next question is, what if a patient refuses to comply with any of the metrics, such as breast cancer screening? If the doctor documents that, does that count as being met?
Hi, this is Angie. No, it does not. You can only answer yes for the numerator if the patient was screened for breast cancer during the measurement period or the 15 months prior to the measurement period. Thank you.
Thank you. And Stephanie, I think we can take that other phone question right now.
Our last phone question is from Meg Richardson.
Hi, yeah. I was just wondering regarding the EIDM accounts. We have the same group of people that had accounts last year that will be performing chart review this year. So is there anything, I'm assuming they all continue to have active accounts. Is there anything special they need to do, or can I assume that they're all set to go this year?
I'm sorry, I missed the question.
Okay, yeah, no problem. So we have the same group of people that they have EIDM accounts. They're all set up as, the ability to, I forget exactly the role, but the, web interface, have ability to upload to the web interface. If they had active accounts for the 2017 review, can I assume that they still have active accounts? Or do they need to do anything special to log on?
They should migrate across. They may need to reset their password, but they should migrate those accounts and roles across.
Okay, great. Thank you.
And this is Sandra. To add on to Chris's response, we suggest that people with access log into their account just to make sure that they still have access and to change their password so that they're ready when the web interface opens.
Thanks.
Great, thank you. And this next question is, will the sample be provided on January 7th and January 22nd? Or apologies, will the same sample be provided on those dates, the 7th and the 22nd?
Hi, this is Sarah from ACOPAC again. Yes, it will be the same sample.
Thank you. This next person asks, when you are in QPP and you look at eligibility and reporting, should you currently be able to see if you are associated to a practice or ACO? And they say they see it under Manage Access but not under eligibility.
Hi, this is Sandra. Could you please contact the help desk with that question?
Okay, this next question is, how long do we have to keep supporting documentation for a possible future audit from CMS?
Hi, this is Sandra. For Shared Savings Program ACOs, we select the ACOs that will be audited soon after the web interface closes, and we will communicate with ACOs concerning the audit.
Great, thank you. This next question is, if we upload multiple files with different information entered, will the later file overlay or override the first file? And this person says they're confused about the blank spaces and how that impacts the overall submission.
Hi, this is Aslam. If you upload a file that will be entered into the CMS web interface, later you do another upload with different information. For example, if you change a beneficiary data that you have entered in the first file upload, upon your completion of the second file upload, the new data you have entered will overwrite the initial data. If you do a file upload, later you do a second file upload with partial information, only the information that you have filled out will be entered, will be uploaded to the web interface. If you have beneficiaries in where you have not entered any data and you left the Excel questions blank, then the upload process will skip those fields where there is no information included, and no data will be entered for those beneficiaries and those questions with the blank fields. If you have entered data into the web interface and later you would like to remove the data that you have entered, then you would select an NA option in that measure question or in that measure answer that you would like to wipe the data. Then at the end of the upload process for the question that you have entered NA will be erased. Your response for that question will be erased from the system. Does that answer your question?
And that was actually a chat question, so
okay.
Hopefully that answered their question. But of course, to anyone on the line, if your question hasn't been answered or if you do have further questions, please feel free to contact the QPP Service Center or those other emails located on slide 58 for the Medicare Shared Savings Program ACO and Next Generation ACO. So I think we have time for just one last quick question. Could you define active diagnosis of bipolar? What is an active diagnosis?
This is Jessica from the PIMS team. So an active diagnosis is defined in the MH1 spec on page 9 in the denominator guidance box at the bottom of the page. And it reads, active diagnosis is defined as a diagnosis that is either on the patient's problem list, a diagnosis code description list on the encounter, or is documented in the progress note indicating that the patient is being treated or managed for the disease or condition during the denominator identification period. If you have a situation that you feel is not answered by that definition, please feel free to contact the Quality Payment Program, and we are happy to look into it for you. Thank you.
Thank you, and that is all the time we have for today. So thank you everyone for joining, and feel free to join us in the next webinar on January 9th, 2019.